Thank you so much. I really appreciate the invite, and I'm really humbled by everyone that's come to listen to me today. And I really hope this is an informative talk. It's a very important and hot topic area, and I think something that we need to do a lot better in. Before I start, I just need to acknowledge a few things. So my funding from the Birmingham Biomedical Research Centre and an ESPRC grant for AI to accelerate healthcare research. I'd also like to thank a key collaborator of mine, Gary Collins, who's worked on a lot of these aspects with me. So today I'm talking about prediction models in healthcare. And as a statistician, I do a lot of reviewing. For example, I'm an editor for the BMJ, and we see a lot of prediction models that are sent to us. And a lot of the quality of these things is not very good. And this is in the BMJ, which is one of the best journals, I think, in the world. When you go down to lower impact journals, the quality of submissions gets even worse. So this is something we need to be raising awareness about and doing a lot better in. So prediction models in healthcare, a playground for research. I put a question mark there, but there really is no need for a question mark because this is a playground. Lots of people are dabbling in this area, and it's something that's getting out of control, and we need to do better. So let's crack on. It's important to look back and see sort of where we've come from. So when we're talking about prediction models, we're often talking about forecasting and looking into the future. And there's this brilliant quote attributed to Galen in the second century AD. Patient trust was essential in the healing process. It could be won by a punctilious bedside manner, by meticulous explanation, and by mastery of prognosis, an art demanding experience, observation, and logic. Mastery of prognosis. If you read the prognosis research literature, you will realize we're a long, long way away from mastery of prognosis and prognosis research. So let me just start by an introduction to prediction models in healthcare. So when I'm talking about prediction models, I'm talking about a statistical equation or a artificial intelligence system, a neural network, a random forest, some type of machine learning approach, which takes values of predictors, sometimes known as features or prognostic factors, and uses those to estimate the outcome risk for a particular individual. So this is about individualized risk prediction. In people like me, what is the risk of a particular outcome happening? And so therefore, with making predictions, we need a model that's giving accurate predictions that reliably inform patients and health professionals about their future outcome risks, guiding healthcare decisions that ultimately improve outcomes. And we also may be using prediction models to improve research itself, for example, in clinical trial randomization. But the focus is on estimating predictions for individuals, so individualized predictions. Here's an example that I use a lot because it's just a very simple example. It's the Crash tool, and this is displayed as a web app. And this is a tool giving you the risk of outcomes in individuals that have had a traumatic brain injury. So it's like a severe blow to the head. And here the predictors are country, age, Glasgow Coma score, etc. And you plug in the values of those predictors. So this individual from Australia who's age 47, they've got a Glasgow Coma score of 9, etc. And then behind the scenes, there's some algorithm, a model. Here it's the logistic regression-based model. And based on these values and the underlying predictor effects in the model, we have an output here. It's the risk of 14 days mortality, which for this individual is 14%. So we've got a personalized individual risk prediction tool based on multiple predictors, a multivariable model, giving us an individualized risk prediction. So we want to know whether those models are good because they are being used. So in the UK, we have a governing body called NICE who decides essentially what treatments are going to be implemented in our National Health Service. And you can see in NICE guidelines that risk prediction models are mentioned a lot. So you may have heard of the Q-risk score or the Nottingham Prognostic Index or the FRAX score or the APGAR score for newborns, the Leicester Diabetes Risk Score. There are many, many models that are being recommended for use. So clearly, if we want models to be recommended for use, we need them to be reliable. They should be accurate and clinically useful. And therefore, we need to know as reviewers or as people who are stakeholders, patients, and we're all patients, clinicians, health professionals, what the model's performance is. So does the model give estimated risks that closely calibrate with observed risks? Do they discriminate between those who will and will not have the outcome? Does the model, if you used it in practice to guide decisions, for example, based on a particular risk threshold, so above 5%, then we'll treat, less than 5% risk, then we won't, does that approach have clinical utility? And do you know these measures, and have you seen that the model works well in the target populations of interest? So not in a small, narrow sample, but in a population that is representative of the population where you want to apply it to. So just to go on a little bit more in detail on those things, calibration is the agreement between the observed risks and the estimated risks from the model. And we often examine this through measures such as the calibration slope, but also plots such as the calibration plot and statistics I'll show you in a second. Discrimination is a measure of how we separate between those who will and will not have the event. We often measure this through the C statistic, or for binary outcomes, this is also the same as the error under the receiver operating characteristic curve. And for clinical utility, we may do a trial to examine the impact, but we can also use measures such as decision curves and net benefits. I'll come on to these things throughout this talk, but I'm going to focus a lot on calibration because this is a measure that's really neglected, particularly in the machine learning literature. So here's an example of a calibration plot. So a model was developed for 30-day mortality following acute myocardial infarction. And the calibration plot gives us the estimated risks from the model on the x-axis against the observed risks on the y-axis. So we have a validation data set, and we want to see if the observed and the estimated risks seem to agree. Well, down the bottom end here, we see that the risks do quite closely agree. To the dotted line is perfect calibration, ideal calibration. Those with very low risks have observed very low risk as well. But as we get a bit higher, we see that the estimated risk is probably too big. There's some miscalibration. Those with risks about 0.8, actually the observed risk is around 0.6. This is really well displayed by this blue line. This is a calibration curve, a smooth calibration curve fitted throughout all the data. What we often see is just these green groupings. For example, you often see 10 groups, and we look to see the calibration performance in those 10 groups. But we don't need to do that. We can just use all the data set and look at this smooth calibration curve. The C statistic for this model is 0.81. Whether that's good or not is context specific, is very difficult to say. But most of the machine learning literature just focuses on a C statistic. And they might look to see if the C statistic is bigger for your model than a previous model. But very rarely do we get these calibration plots. And when we're thinking about healthcare and patient-level decision-making based on individualized risks, it's very important that we have calibration, particularly in ranges where clinical thresholds may exist. So the playground of prediction model research. So let's just talk a little bit about some of the problems. One of the problems we've got in England is our football team, that we just don't win anything. And Steve McLaren, when he was manager of our English national team in the 2000s, he came out and said, we have to reduce our expectations of England, and we have the players to do it. And we certainly did have the players to do it. We constantly had to reduce our expectations with those players. But the same is true with prediction models. Look at this slide, which was kindly supplied to us by Martin van Smeden. This is a summary of, and it needs to be updated even now, but of all the different models available for different disease areas. So like for COPD, there were 408 models, cardiovascular disease, 360 models, 260 models in obstetrics, 260 models after a general trauma, etc., etc. There are hundreds of models in every disease field. Now, most of these models are just not very good. And should never be used. Probably most of them, nobody's done much about them. Some of them I worry are being used and are being used wrongly and are going to be harmful. Very few have been validated in new data. Calibration, clinical utility, rarely assessed. And most of these models are not really being created anything more than people wanting an academic publication. I think people have a data set, they fit a regression model, they publish it in the journal somewhere, they can put it on their CV, and that's the end of the story. But it's leading to a body of research that is really, really not helpful. And within that research, there's a lot of bad methodological practices that then get repeated and repeated. And we need to push back. As a methodologist, one of my roles is to push back against poor methodology and promote good methods. During the pandemic, there was a chance really for prediction models to take center stage. So it became very clear at the start of the pandemic that many places would need to stratify who to treat first. So who to admit to hospital, who to prioritize vaccines to. And therefore, prediction models were greatly needed. The problem was that most of the literature was of poor quality. So there's this review, a living review, the first living review published in the BMJ, led by Laura Wynant and Martin van Smeden. And I was fortunate to be involved in this. But Laura and Martin, at the start of the pandemic, very quickly moved to start to do a systematic review of existing prediction models in COVID-19. And they, within a few months, had a publication in the BMJ. By July 2020, so just a few months after the pandemic, there were already 169 studies reporting prediction models, and there were 232 models that had been proposed. That's just in a few months. The quality of those was appalling. So when we did a risk of bias assessment, there were lots of issues. I'll just very briefly go over them. For example, participants, 42% of the studies had a high risk of bias, that the participants of the studies were not representative of the target population. Some studies didn't even recruit COVID-19 patients. They just generated some synthetic data. The predictors, many predictors in the models were not measured at the time the model was supposed to be used. So you'd never have those predictors available when you would want to make the prediction. Some predictors were part of the outcome definition. So clearly, you can't be predicting the outcome from something that you've already know what the outcome's for. And then the analysis domain, we had 94% were at high risk of bias because of issues such as small sample sizes, overfitted models with no adjustment for overfitting, continuous predictors were dichotomized, reporting was terrible. People were fitting models without accounting for the time to event, the censoring. There was no validation, lots and lots of issues. People rushing to get papers out, but they're not good quality. I'll skip that. That basically is just saying that by the stage that we did our final update in 2022, there was 731 models, and 90% were high risk of bias. But there were some good ones, and I'll come on to those in a second. Here's an example of a model where I would say there's a lot of concern. So this is a model by Guana, published in the Annals of Medicine. And they say that the simple tree XGBoost model, machine learning method, conducted by the predictors, the features in the model, can predict death risk accurately. Okay, so that's a very strong statement. Yeah, very strong statement. What was the sample size? The sample size, they had 16 events for development, and for validation, external validation, they had 7 events. 7 events is not enough to validate a model. This is their error under the curve plot. You can see, because they've got few events, you've got these huge steps. And you get some weird results with small sample sizes. So for the logistic regression or XGBoost models, they're getting a C statistic of 1, perfect discrimination, confidence interval of 1 to 1. You're only getting these weird results because you've got such sparse data, and there's no calibration checks. You also get spin So, for example, even when people do present a calibration plot here, this calibration plot for another model, COVID model, clearly there's miscalibration here. The predicted risk and the observed risks are not agreeing, and we're nowhere near this diagonal line. We've got systematic over prediction down here, then it goes the other way around up here. So there's a problem. Well, the authors didn't think so. The calibration curve showed a good agreement between the predictive risk and the actual probability. It doesn't, but that was their interpretation. Here's another one. Again, you can see huge miscalibration, but the summary, good calibration. The p-value for the tested calibration, miscalibration is 1. But again, this is simply because you got a tiny sample size and you're spinning the results. So there's so much of this going on. It gets very frustrating, as you can probably hear in my voice. Let's just turn it around and focus on something that I think is a very good model. This is a model led by Gupta et al., published in the Lancet Respiratory Medicine. They did extensive internal and external validation of models in very large samples. They did assess discrimination, but also calibration and clinical utility, and the performance showed good generalizability. So this was their calibration curve. You can see this is a model is very well calibrated. The red line, the calibration curve fit through all the points, is close to the 45-degree line. They examined, this was in the UK, performance not just overall, but also in sub-regions. So the east of England, the Midlands, Northeast, Wales, Scotland, etc. We've got C statistics in all these different regions. We've got measures of calibration in terms of calibration large and calibration slope. That's just a summary of that calibration plot that we had on before. And we're seeing performance that overall is very, very good. The calibration slope should be 1 if it's ideal calibration. We see 0.99 here. So we've got a real interrogation of performance that's based on the large sample sizes. So we need to be encouraging methodology like that rather than with small sample sizes and misleading, inconsistent findings. But it's very hard to stop people from developing models. Again, going back to football, Paul Gascoigne, very famous English footballer, you will have heard of him. He once said, "I never make predictions and I never will." Obviously, still making a prediction. Andrea Leadsom, you won't have heard of her, hopefully, but she was an MP and she was very pro-Brexit. And in a radio interview, she was asked about the future for the UK. And she said, "I have never and will not start predicting the future. I don't do predictions ever." A few hours later, she went on the radio show and she said, "I'm a very strong Brexiteer. I genuinely believe that we have a bright future ahead of us when we leave the EU." So it's hard for us to stop making predictions. And therefore, we're still going to be making predictions. We need to make sure that our methodology is right. And this is never more important than in healthcare, because in healthcare, our predictions are influencing decisions about who receives treatment, who is kept in hospital, who is admitted to hospital, who do we monitor more often than others. So this is the challenge that I want to put to all of you today. So the take-home message is that we need to strive for better prediction model research. We can do that through some very important ways. Register your projects. Yeah. It's not just trials that we should be registering our research of. Register your projects. Publish your protocols. Publish statistical analysis plans. Why not start by validating or evaluating a model? So rather than simply starting to develop a new model, why not see what's already been published and try and validate or evaluate that model first? Maybe it works, and then you don't need another model. You don't need the 400th model in CVD when there's already 399 there, and maybe one of them's good. Include statisticians and health data experts in your research. I think, we do have experience of working with excellent clinical academics, and some of them have excellent data analysis skills. But statistical analyses is a professional expertise. So engage with professional experts in the development and validation of a prediction model, because they have the experience and the knowledge to do it. Conversely from that, statisticians don't just develop a model because you've got a data set. Work with clinical experts to understand the research question. Why is the model needed? What will it be used for? What are the relevant clinical thresholds that may be of interest for making decisions? And then clearly report your project methods and findings at the end of your research study. So in relation to reporting, I want to tell you about the tripod reporting guideline briefly. So Doug Altman, who was a close collaborator of mine, he said, good reporting is not an optional extra. It is an essential component of research. This ultimately led to Doug and Carl Moons and Gary Collins producing the tripod statement. This is a reporting guideline for prediction model studies. And the update to this, Tripod Plus AI, is coming in the BMJ in the next few weeks, I hope. So look out for Tripod AI and go to the tripodstatement.org to see the latest version of that. So use that for reporting prediction model studies. And there are extensions to systematic reviews and clusters and protocols and things as well. Another simple thing that we can do better is stop dichotomizing continuous predictors. So most models you'll see for continuous variables like age split into two groups. But the cut point, like here's 65, that you use to do that is completely arbitrary. Why are you choosing 65? Why are people aged 64 and 65 different? Why are people aged 23 and 64 the same? It makes no sense. Cut points leads to worse performance, data dredging, rather model non-linear relationships. So with statistical regression models, it's often criticized by the machine learning field that these methods don't allow complex relationships. Well, they do. Allow this using splines or polynomials, for example. If you do want to create groupings, this can be done after the model has been developed on the risk scale, not on the continuous predictor scale. Also evaluate the performance reliably. I've mentioned already calibration, discrimination, clinical utility. Examine those things in the target population of interest. And don't just examine it overall. If you've got enough data, look at different regions, practices, subgroups. Gary and I led a series of 3 papers that have just been published in the British Medical Journal called The Evaluation of Clinical Prediction Models. And we go from part 1, an overview of the whole validation approaches, to part 2, focusing on external validation, and then part 3, focusing on the sample size needed. So if you want to have a bit further reading, this would be a good place to start. I've mentioned calibration and discrimination, but these are not necessarily the be-all and end-all either, because it depends on the clinical context. So if I go back to this model I had on earlier, I said, oh, it looks okay down here, but not as good up here because there's some miscalibration. So the estimated risks are too high. But does that matter? So calibration is not perfect, but it occurs mainly in regions, let's say, from a risk of about 15% onwards. Now, what if actually, in this clinical context, anyone with a risk over 5% was deemed to be high risk? So if I predicted a risk of 0.8, when actually their risk is about 0.6, it doesn't matter. It doesn't matter because they're still high risk. Therefore, the miscalibration really is context specific, and that's something that's not quite understood either. This is why working with clinical experts is so important. It could still be clinically useful, this model, even though there's miscalibration. And we can evaluate clinical impact through cost effectiveness modeling, through randomized trials. We randomize some people to receive the model and others not to receive the model. But an initial thing that we can do after model development or in an external validation study is a decision analysis approach. And we evaluate a measure such as net benefit, the clinical utility. This is an approach that weighs the benefits from using the model against the harms, for example, the costs, worst outcomes. And this basically comes back to this idea of a threshold. So let's say there was a threshold of 5% or 10%. This threshold defines the underlying benefit to harms ratio that we're willing to have. So you need to understand how the model is going to be used, what the thresholds are important. We need to speak to patients and clinical advisors about that. So if a threshold was 10%, we're willing to treat 10 individuals so that one benefits. We go back to that MI model. I said there was miscalibration. Remember, I said miscalibration over here. However, if the threshold was around 0.05 to about 0.4, this figure, which is a clinical utility figure of net benefit against the threshold probability, we see that this black line, which is for the model, has a higher net benefit than this dashed line, which is just treating everybody regardless of their risk, or the horizontal grey line, which is treating nobody. So we can evaluate measures such as net benefit after our modeling to see and measure clinical utility in terms of performance. I know that's a little bit complicated and I haven't got time to go into it in more detail, but it's just something to really remember. Something that's really passionate to me as well is thinking about how we can develop a model that's stable. So how can we develop a model where we know that the predictions from that model are likely to be reliable and not very, very uncertain? So I talk about stability. Models are more likely to be reliable and stable when you're using large sample sizes, representative of the target population, that you're not overfitting, you're not fitting thousands of predictors relative to the number of events, that we use approaches to address small amounts of overfitting, such as shrinkage and penalization approaches like the lasso or ensemble methods from machine learning literature. We use resampling methods such as cross-validation and bootstrapping to examine and maybe adjust for optimism. And we can examine concerns of unreliability and instability through approaches like bootstrapping. So bootstrapping is a very powerful approach where we can resample our original model development data, our training data, and see if we repeated the model that's being developed again and again and again and again and again, how much our predictions will change. So Gary and I published a paper in the Biometrical Journal at the end of last year, Stability of Clinical Prediction Models Developed Using Statistical or Machine Learning Approaches. So I just want to show you some results from that paper. Think of it like this, that if you're developing a model and you're throwing everything into it, hundreds of predictors, but actually you haven't got a big sample size, you're going to end up with this hugely unstable and dangerous problem that's about to explode in your face. So just to clarify, instability is the idea that if you developed your model again in exactly the same way that you've done it before, but just by using a different sample of the same size, then the model would look very different. So for example, the intercept term would look different. The predictors you select would look different. The tree structure, the predictor effects would look different. And because the model is unstable, the predictions you get are unstable. So for example, one model might give Sam an estimated risk of 0.2, but another model that you happen to could have developed in a different sample could have given Sam an estimate of 0.7. If you've got that instability, then it's a red flag that this model is not going to be fit for purpose at the moment. The larger the instability, the more concerned the model is unreliable. And we should always examine that. And we can do that through bootstrapping. And there are various other papers that talk about instability as well. I'm just going to skip a couple of slides and go on to a real example. So let's develop a prediction model for the risk of death by 30 days after a heart attack. And I'm going to use a massive data set, the Gusto-1 data set. And there's 40,000 individuals, nearly 3,000 deaths. Overall risk is about 7%. And I'm going to fit a lasso logistic regression model with these 8 predictors. And I'm going to use bootstrapping to examine the instability of my model. Okay, so here's using the full data set. So let's just talk this through. So I fitted a model to the full data set using a lasso model. And I've got my predicted risk from that developed model. But then I've also developed 1,000 other models, the bootstrap models, using 1,000 other data sets of the same size using bootstrap resamples of the original data. And for every individual, I'm plotting their original risk. So this is an individual that's got an original risk of 0.2. And on the y-axis, I've got the 1,000 risks estimated from those 1,000 bootstrap models. And the dashed line is my 95% interval. So for individuals with a predicted risk of 0.2, across the other 1,000 models that I could have developed, their risk is very, very tightly around 0.2, from about 0.18 to about 0.22. And that's the same for nearly everybody. Everybody's instability is very minor. Clearly, this is in an enormous sample size. If you developed it in a smaller sample size of 500 participants, so now I've got about 4 events per predictor. Now what we're seeing is a problem, because we've got, for this individual with a predicted risk of 0.2, that their actual estimated risk from a different model could be between 0.4 down to about 0.1. For an individual with a risk of 0.8 from the original model, we could have had another model that gave a risk of 0.9 or down to about 0.3. So there's uncertainty, and you can think of this as an uncertainty interval based on the model you've developed and the approach that you've used and the predictors that you've used. How stable is that original prediction from that model you did create? Whether this is important or not, again, depends on clinical thresholds, because if you've got an individual whose risk goes between 0.1 and 0.4, then if thresholds are around 0.15, then this could be a concern, because you've got a lot of uncertainty about whether they're higher than 0.15 or lower than 0.15. But again, at this end, if the threshold was 0.15, this uncertainty might not matter as much. But clearly we want to be on this side, don't we? We want to be over here. We want to be having stable models. You might look at the C-statistic on this right, and the C-statistic goes from 0.77 to 0.83 across the bootstrap models. So that's quite stable in theory. So what you're not seeing from the C-statistic is this problematic individual level variability in predictions. We could also look at calibration instability. So how do the bootstrap models calibrate in the original data? With a very big sample size, our calibration curves are quite stable. There's not much variability. When you go back down to that smaller sample, look at the calibration curves now. We've got huge uncertainty in the calibration curve. So again, if you're wanting to get a stable model that's well calibrated, then clearly smaller sample sizes with sparse numbers of events, 35, are going to lead to miscalibrated predictions. And again, for healthcare decision-making, that's not something we should be doing. You might argue to me, well, hang on, don't artificial intelligence and machine learning methods already address this? Well, modern methods do try and reduce the variance and the bias-variance trade-off. We have ensemble methods, which try and aggregate predictions across multiple models to try and reduce the instability. We have penalization methods, like I said, but these don't solve the problem. They don't solve the problem. For example, random forest is a popular ensemble method that uses bootstrap aggregating to average across multiple models. Let's have a look how this performs here. So on the left, I've got my small data set, and I've used lasso logistic regression. On the right, I've got my small data set, but I've used a random forest, and I've just used the default settings. Look at the instability here. We see that individuals, well, most of these individuals have an uncertainty interval that goes from 0 to 1. Yeah. So you've developed a model, but actually it's so unstable that risks in another model that you develop could go from 0 to 1. That's using the default settings. If you were to be a bit more refined and considered, for example, fix the tree depth to 3, then we have a much more stable random forest, not too dissimilar from the one on the left from last logistic regression. So that's just a warning that our tuning parameter approach is also very important to the stability issue. But it doesn't matter that, in a sense, if you've got your sample size right, that's the most important thing. So last 5 minutes. I just wanted to emphasize that I'm not having a go at machine learning methods per se. What I'm worried about is people just applying machine learning methods without consideration of things like stability, calibration, sample size. The debate isn't about machine learning methods versus statistical regression-based methods. That is not the debate. The debate is about making sure that you're using the right method for the research question of interest in the context of the sample size that you've got available. Many machine learning and AI methods do require a larger sample size. They're by nature allowing more complexity and interactions. So if you're going to allow for that by default, then you need a larger sample size. Otherwise, you're going to get more instability. And I think at the minute, people are just applying these new methods without thinking about statistical issues of sampling variability. And then even at the end of those, they're trying to explain models with explainable AI. Well, you can't explain a model if it's hugely uncertain. Okay, so if it's an unstable model, don't even try to do explainable AI. And then to finish, I want to mention about sample size. So without a sample size, you're in trouble. For regression-based methods, we've developed a variety of methods to try and give people an idea about what sample size you need as a bare minimum. So, for example, you can think of that if you're estimating developing a model with a focus on binary outcomes, surely you need the sample size to at least be large enough to estimate the overall risk precisely. If you can't estimate the average risk, the population risk in your data set precisely, then how can you estimate individual risk precisely? So target sample sizes that at least estimate the overall risk precisely. Also think about estimating small mean absolute prediction errors, targeting small amounts of overfitting. These ideas are embedded in a package called PM Sample Size that's been produced for R and Stata by Joey Ensor at the University of Birmingham as part of our sample size work. This was developed based on theory for regression models, but it is relevant for machine learning. I can't emphasize that enough because most of the time I think machine learning methods require a larger sample size, like I've said. So the focus on this is to develop well-calibrated models that are stable, but even in those situations, this is a minimum and the instability may still be quite large even from following our criteria. Here's a very quick example. PM sample size was applied to a binary outcome. We have to put in some default thoughts about the C statistic or the R squared performance here, 0.2. How many predictors, parameters we're putting in. What's the prevalence of the outcome, the overall risk, 0.5. We have 3 criteria it's looking at, and we find that the criteria to minimize overfitting in terms of the calibration performance gives a sample size required of about 1,200. In this situation, about 20 events per predictor parameter. Okay, so have a look at the papers around PM sample size if you're interested in that a bit more. And lastly, we've just released PM val sample size. This is the sample size required for a validation of a prediction model. And this is aiming to identify the sample size needed to target precise estimates of calibration, discrimination, and clinical utility. So again, if you're interested in doing an external validation study, have a look at PM val sample size, which is now available. So in summary, we're a diverse community of data scientists, statisticians, clinical academics working in prediction models. And we all identify differently. Some identify as machine learners, health analytics, AI, statistics. This was a slide that I got from Twitter, but the key thing I want to emphasize is that it doesn't matter how we identify ourselves. We all need to come together to improve the quality of the prediction model field because current standards are very poor. We need better training and education in this field to enforce higher standards. My personal view is that we should be aiming for stable models, particularly in healthcare. Maybe it doesn't matter in other areas. For example, Google searches or Amazon recommendations. Does it matter? But in healthcare, where we're making patient-level decisions, it does matter. Therefore, we need to focus more on evaluation, clinical utility and impact. And all these things, I think, we need better understanding of sample size calculations. So I'll just leave you with some references there, which are very, very self-indulgent because they're mostly mine. But anyway, they relate to aspects of this talk. So check those out. I've also got a website to educate people new to the field, prognosisresearch.com. And we do deliver a couple of courses at Birmingham on prediction modeling if you're interested in coming to any of those. But thank you so much for listening, and I hope that's been really informative. And yeah, let's have some questions. Thank you.